I don't know who's up this morning, but good morning, Bill.
Maybe not too many people.
I'm with Dr. Bill Wood, and we're doing a Doc Talk Live. I like your scrubs, by the way. You wear figs as well.
Like yours.
We should get an advertisement for figs.
A little kickback.
Dr. Wood is a general surgeon,
Correct.
and we're going to talk this morning a little bit about hernias. And if people aren't catching it live, they can hopefully find it later. So just tell us a little bit about what a hernia is.
So a hernia, as most people think about it, is an opening or a defect, usually in the abdominal wall, that will allow structures that should be inside the abdominal cavity to kind of protrude out. And they can be painful, they can be dangerous, they can be asymptomatic.
If they're asymptomatic, does anything need to be done about it?
It's a good question. In general, yes, because hernias, as a rule, are not going to improve on their own, except for a very small subset of the population, usually kids under 2 years old. And so the danger in the hernias, as they increase in size with time, then more and more of the structures in the abdomen, such as intestines, can protrude out, and that can cause problems. If the intestines were to twist, or the blood supply were to be compromised, intestines could, for instance, die and cause life-threatening problems, or they can cause intestinal obstruction, which is also a life-threatening problem.
How common are hernias?
They're pretty common. We see them a lot. They can be either congenital, in other words, present from birth, or they can be acquired as a side effect of things like surgery. Anytime there's been an incision on the abdomen, there's a risk that that area is not as strong as it once was and can lead to a hernia. So in our practice, we see them fairly often.
But mostly in your practice, I guess, since you're treating mostly adults, is that right?
Yes.
So you would see them more as a complication of surgery? Is that accurate?
Not necessarily. We see a lot of, for instance, groin hernias in men that are not complications of surgery. They're very common just by the nature of anatomy and embryology. There are potential weak spots in that area of the abdominal wall. And so we see quite a few hernias that are not complications of surgery.
You have a hernia up here, is that right?
Yes.
Let me see if I can focus this, okay? Yeah, I think we're pretty good, actually. I'm going to come closer. Good.
So
all right.
This is a CT scan of the abdomen, and just for orientation, this is the liver, this is the gallbladder here, here are the kidneys, and as we come down lower on this patient's abdomen, you can see this is the abdominal wall. It becomes irregular here.
So just to back up, I'm sorry, the patient is basically lying on their back.
Correct. They're lying on their back.
Their head is going into the wall,
Right.
And their feet are coming out at us.
Exactly.
Okay, so they're oriented.
So this is the patient's right side. This is the left side. This is their spine. Their pelvic bone's right here. And so here at the abdominal wall, there's intestine here, and this is intestine that's outside of the abdominal cavity in the abdominal wall, and that should not be there. So in this patient, the intestine has been squeezed, and it's causing a partial obstruction. And we can see the intestine bigger than normal up here upstream from the hernia. And so this is causing a partial or worse intestinal obstruction. This patient actually had to undergo a pretty serious operation last night to correct this, and this intestine's blood supply had been compromised. We had to remove this short segment of intestine and then connect it back together to get that back into our abdominal cavity.
So this intestine actually died, is what you're saying?
Correct. And so obviously that's a life-threatening problem. You don't live too long with dead intestine.
No,
that either gets fixed or,
right.
You don't do well.
I'm gonna just slide back here. When should somebody be checked for hernias if they're asymptomatic?
Well, some people have hernias and are not aware of it. If they're asymptomatic and nobody's examined them, they may not be aware they have a hernia. But any sort of, bulging at the abdominal wall, unexplained bulging, and classically, the bulging is something that can come and go. If you push on some hernias, you can make that bulging, or those intestines that are out, go back into the abdominal cavity. They'll frequently just pop right back out.
Do these hernias, can they just be watched? I mean, obviously this became a life-threatening problem. So how do we, where is that sort of continuum versus, because no one wants to get to this
Right.
point. How do you know?
And nobody wants to have surgery unless it's necessary either. Well, the hernias, the people that get watched for with hernias instead of repaired are typically people who are prohibitive operative candidates, people that are really high risk to have anesthesia or are trying at all costs to avoid operation, even though they may be counseled this could end up being a life-threatening problem. So, but as a rule.
But if you're asymptomatic, right?
Right.
Why would you want surgery?
Well, you don't want it to get to this point.
Exactly. So, is there a way of monitoring that or not?
You can monitor as long if a hernia is not increasing in size, then the risk may be less. But the bottom line is, a given size hernia can become a problem even if it doesn't get larger. So there's really no way to predict exactly what the clinical course would be. And so that's why, in general, you should be thinking or at least have a plan of getting a hernia fixed, even if it's asymptomatic.
And what about you mentioned hernias in the groin? Can you speak a little bit more about those? Are those generally more painful than the abdominal hernias?
I don't know that they're necessarily more painful. We'll see more of these types of hernias in men than women, although women can get them also, and they're caused by something that's not the patient's fault at all, but has to do with embryology, the way that the testicles migrate as in utero from the abdominal cavity down into the scrotum. So this pathway that the migration occurs can remain open or patent, and that serves as a pathway for a hernia to gradually enlarge over time. And those can appear in infancy all the way up through the rest of a patient's life. And so they can be painful. They're sometimes completely not painful, but typically there'll be a bulge in that area, and it just gradually gets bigger over time and more symptomatic until it gets repaired.
Now I'm going to throw a curveball at you.
Okay.
So this is not a fair question, but I'm going to ask it anyway. Sports hernia. And the reason that's a curveball, it's not really a hernia, is it?
Well, there's a lot of controversy about this, even amongst hernia specialists. I was at a symposium regarding hernia repair some years ago, and even one of the foremost experts in hernia repair acknowledged that there's a lot of controversy. Does this entity even exist? This could be. There's a lot of complex muscle layers that come together in the groin or inguinal region, and so this may represent just a pulled muscle, muscular strain.
Right.
Or could it be a very small hernia that you can't really detect on physical exam? And so, it doesn't come up as much in my practice. Our patients are not, as a rule, we don't have a large percentage of our patients who are
playing soccer in their 50s
in the NFL and whatnot.
Yeah.
So when we encounter patients with groin pain, if we can't feel a hernia, then sometimes imaging will be sought, like a CT scan, similar to this, and that can pick up hernias that are smaller than what we can detect when we actually examine a patient.
But those could be asymptomatic, and so I guess you can see how that could be a gray area.
Yeah, it's definitely a gray area, and you individualize care for every patient. Excuse me. Patients that are risk averse, that want to be as conservative as possible, don't want to see the hernia become a bigger entity later, are going to be steered towards getting an operative repair. The operation for a large hernia is in general going to be more involved and more invasive than an operation for a smaller hernia. So somebody who wants to remain very active, it might be prudent to get it repaired earlier rather than later.
I'm sure there are questions on hernia that I haven't asked. So anyway, if people have more questions about hernia, how would they find you? Is there a website or anything like that?
We have, easternsurgical.com is our website,
okay.
And we can be contacted there. And there are plenty of resources online to read about hernias.
Mm-hmm. Do you do hernias in the outpatient surgery center at all?
We do some in the outpatient center, and then for some of the newer techniques, for instance, laparoscopic or robotic techniques, we'll do those over in the hospital operating room.
So you can do those with a robot?
We're doing more and more hernias robotically. People have heard about the robotic device, but the advantages are it allows more control. It's almost as if your hands and wrists are inside the operative field. You have more of a wristing action inside, and so for operations where you're going to do suturing and sewing, it can facilitate things, and you get a much better view. The camera it has two cameras on the end of the scope, and so it's actually a three-dimensional view, and you really get a depth perception.
That's what I want to show. Any chance Would you object to us somehow doing a Doc Talk Live showing a hernia repair?
Sure, that'd be fun.
Yeah, if we can get the appropriate consents from
Sure,
God and everybody else.
Sure, we talk to the patient first. And, yeah,
but it's not. It's usually not the patient that's the issue. It's the I don't know, the layering of administrative stuff that somehow.
But I bet we could work through that.
All right. Well, that'd be fun. I want to thank everybody who got up to listen to this, and hopefully you'll catch it later. Bill,
Thanks,
appreciate
Brad.
it.
Appreciate it.
That was fun. Let's do it again.
Yeah,
Let's try to show a hernia.
Yeah,
That would be awesome.
It'll be fun.
All right, I'm going to finish. Hello. Okay, goodbye. Finish.